Thank you for joining this graveyard shift with me. What I'm going to talk about is the idea of a universal platform for monitoring patients, and those patients can be in any location. And so we're really talking about future hospitals, what the hospital of the future can look like. So what we have, and you may notice across there, you can walk into the forest on our stand, and this really is the hospital of the future, the hospital without walls. And what we do at iSansus, we look at the patients. We're really concerned that things are going wrong everywhere around the world, but we want every patient to be safe. And to do that, we monitor them, we connect them, make them safe. And so one of the things comes out of this is this idea of a real virtual ward. I think a lot of work around virtual wards has been kind of rebranded telehealth. Very effective, but not at the level of being able to provide hospital-grade care at home. And that's really what we're trying to do here. So when I was putting this together, and often I think about this, what is a patient? What is a patient? The patient, what makes us patients? And it's always it is defined by our relation to a healthcare service. We are the receivers of service provision from the healthcare provider. Otherwise, what are we? We're consumers, we're individuals, but we still talk about patients. And patients are often talked about, yes, we have to have patient-centric care, the patient is at the center of care. Very often we don't actually see that. And we don't see it because one of the things that will come out of this talk is we don't really understand what is happening to the patient at all points of that so-called, but the patient journey. So what if we knew a lot more? And there's been a number of presentations today and a number of systems around where patients are asked to report on how they're feeling, what they had, what was going on, and this is fantastic. This is starting to listen to this voice of the patient. But what if we were able to get under that as well? What if we were able to provide some more, if you like, objective information or information about the actual physiological status of that patient? And this is what we're trying to do now, and this is what we are doing. Just a little bit about iSansus, if you haven't heard of us. We are a local company, grew out of some work that I've been doing for a long time. We are based in Oxford, or just near Oxford, still privately owned. We have our European company in Berlin. We have an interesting joint venture company, also called iSansus, taking our brand forward in India. We have presence in the US. We haven't really focused there because anybody who knows about this, the US healthcare market is a complete zoo. We're quite a small company. We're not ready for that yet. And our system we call the Patient Status Engine. So what are we really doing? We are, and those of you who may have heard my talk yesterday heard this as well, but what we're actually doing here is connecting patients to the digital fabric. So what do we mean by that? Well, we are taking information from patients, we are digitizing that information, and we are putting it somewhere where the patient, me, you, can be represented by a unique, completely unique, dynamic, data-rich digital image, sometimes called a digital twin. So we are getting very close to this idea of a complete digital twin. So how do we do that? So we do that by providing this connected platform. And the connected platform is this, the Patient Status Engine. So we are taking continuous, very high quality, accurate, vital sign data from patients. And we're doing that with wearable sensors, not watches, not consumer wearables, but wearables which are part of this overall platform, of which I'm wearing some right now, invisible. So we're looking at heart rate variability, which is popping out of that. We can do real-time ECG, you can look at that. Respiration rates, and we're doing some other interesting things with respiration coming soon. Continuous temperature, continuous oxygen saturation, PPG waveforms if they're of interest, and blood pressure, which is currently, we can do it quasi-continuously, or it can be done with standard manually operated cuffs. We can measure orientation, activity, other parameters like that. And importantly, the system is constructed, put together in such a way that nurses or caregivers can add information, and patients themselves can add additional information. Why is that really important? Well, as we go forward, these systems which are now available, they're ready to go, and being able to add that additional information becomes critical to be able to gain the complete functionality of these products. So what we're talking about here is a complete end-to-end platform. It has a way of being able for the data to be entered at the bedside. We have early warning scoring in the system already. We'll talk a little more about that shortly. And then all that data is coming back through a dashboard and is able to be integrated into the electronic health record. And this is what it looks like. So patients, and there can be hundreds of patients with thousands of devices, because this system has now been around for long enough to become reliable, and it's scaled. So we can connect hundreds of patients. Each patient has an individual gateway device. That gateway then is connected through a wireless connection, Wi-Fi preferably in a hospital configuration, into a software server, which is we provide and install within the hospital IT system. And all the information collected in this platform is available on this API here, where it can be integrated into the electronic health record. So that's an important aspect of what's going on here. If you look at this diagram, you'll see that there's a dotted red line. And what the dotted red line is indicating is that everything inside that dotted red line is part of a single Class 2A medical device. So what this platform is a new kind of medical device, which is a combination or distributed medical device that includes the body-worn sensors, the intermediate gateways, the back-end system, but most importantly takes into account that this system has two, at least, wireless links in the data connectivity channel. Why is that important? Well, a wireless connection will always, at some point in time, fail to carry data. The data won't get through. Some of you may have experienced that in this hall today, for instance. There's a ton of equipment in here on Wi-Fi and Bluetooth. Very high level of interference. Data is not always getting through. So you might notice that period might be as short as 10 milliseconds, 20 milliseconds. But in terms of how this system operates, that is significant, because this has to run for days and days and days. So we take that into account. We build this as a single device. It can be dropped in. And so functionally, it's equivalent to a cabled up, very high-end bedside monitor, which is connected into the EMR, and it's ready to go. It then becomes really interesting when we go here. And what we're looking at here is the fact that those patients being monitored with this exactly the same equipment exactly the same wearables, exactly the same gateway device, or at least software running there, are still connected to that EMR. The only change is the wireless connectivity. And that wireless connectivity, again, we've already taken into account the fact that there is perturbations, there is losses and so on, or there's loss of connectivity. So what is it in this system that we can say that might be different? Well, what we can guarantee is data quality, and data quality at that point there. So when we looked at this as a system, we said, what will we optimize in terms of the system design? So we haven't optimized immediacy. In other words, if a patient is being monitored and had a fall or had cardiac arrest, this system isn't designed for somebody to start running, call an emergency response team and go to them. That's not part of the intended use. What we optimized was data completeness. Because it turns out that if you have data completeness, then you can start doing things with that data that mean the chances of that patient having that cardiac arrest unknowingly are very, very small. So what do you actually see? Well, it's still running on our stand, but this is what is shown on the gateway. So set of vital signs, heart rate, respiration rate, and so on. These blue dots, if you click on them, you will get a rhythm strip, full ECG rhythm strip. A dashboard, which is at the back end, so this is accessible via internet connection or within the hospital on the network. And then taking any of those patients on the dashboard, clicking through, you get a set of much more standardized looking patient charts. Again, clicking on the blue things gives you a rhythm strip when there was some ECG recorded. Within this, there is continuous news too being delivered to the care team. So a lot of people in this conference, if any of the clinicians are still here, then you would know this, but what is an early warning score? What is news 2? Well, news, or news 2, is a standardized, threshold-based, arithmetical, weighted arithmetical sum, which takes into account multiple inputs and doesn't just look at one single vital sign out of range, looks at a set of vital signs and says, okay, if that's the heart rate and it's running in the yellow and the respiration rate is in the yellow and activity is high, if the activity is high, that's probably fine because that's normal. But if that activity is low, that would start to trigger a notification or an alert, which is also built into the system. This is the standard news matrix from the Royal College of Physicians and Nurses, scoring 0, 1, 2, 3, and down here there is a standardized response for people in the clinic. So, what's wrong with that? Well, for a start, it was designed to work around observations that were taken on patients about every 4 hours. So, the second thing, these thresholds, which are here, say if we're looking at the respiration rate, 12 breaths per minute to 20 breaths per minute is seen as normal. Outside that range, it becomes abnormal and scores accordingly. But that is based on population statistics. not on personal or a patient's own personal physiology. So that's the current standard of care. So where would we go from here? Well, what these systems are all about and why they are useful once you start to look at building virtual wards is that they become all about the data. And once you start to look at the data, if we can measure, we can make models. Those models can be relatively simple. The news score is the model, but it's a relatively simple one, but there's more sophisticated but still handleable models that can be done. We can predict. If we can predict what is going to happen to a patient, somebody can take early or make an early intervention. So to go back to the system, why doesn't it need to be able to give an alert when somebody's having a cardiac arrest? Long before that cardiac arrest comes, this system has been able to spot the early warning signs of that happening. So it enables a different way of care to start to be constructed and delivered. And one of the things that we're pointing out here is that because we generate the data, we control the inputs, and therefore the outputs are damn good. Because we avoid this idea of garbage in and garbage out. And one of the things about people who are doing AI on this kind of data is that much of their modeling is about trying to homogenize the data or homogenize the data so that it's able to be compared with each other. It makes some kind of normalized sense. But if we put good data in, we don't have to do that. This is hence those models can be very much simpler. So on the theme of personalization, one of the things that is seldom taken into account is the fact that if you take a vital sign reading, you really need to know a lot more about what that reading or when that reading was taken, who it was taken from, the age of that person, their sex, and some other weighting factors, because this is the normal state. Every physiological signal in the body, including the physical and the biochemical signals, will vary enormously, actually, on a circadian pattern, which will then be modulated by a number of other factors, including disease and other things as well. And these are large variations, relatively. So look at temperature. This is shown in degrees Fahrenheit, but normal temperature then is drifting on a daily basis by 3 degrees Fahrenheit. So where's the 98.4 coming from? Right? It's an average. And on body temperature, by the way, it turns out to probably be wrong. We're all running at a slightly lower temperature than what we think is normal body temperature, because that 98.4 or 37 was decided a long time ago. The patient population were soldiers in some of the wars towards the end of the 19th century, and half of them were febrile. And this is true. You can have a look at this. So the measure of body temperature is actually a little lower. Well, that would be a normal average. But anyway, the fact is that all these signals move around a lot. So what this means is that if we're starting to look at measurements on the human body, physiological measurements, there's nothing very precise about it. There's no gain to have something which is 1 point taken every week or even every day if it's 0.001% accurate. No point at all. What is important is continuous measurement, and what we do know is that there's nothing very precise about human physiology, but there's something very personal. And so if we're interested in personalized care, either through personalized medicine, which tends to be around drug provision, or other forms of personalized care, we need to take this into account. Because look at the money that has been spent on genomics, mapping the blueprint of who we are. But actually, by the time my blueprint turns out as me at this age, and gone through these kinds of stages, this physiognomy here is probably unrecognizable and certainly, for most things, not predictable from the blueprint, from the genome. Then we need to be spending a lot more time, energy, and understanding on what this physiognomy is. And it's interesting, isn't it, that it's only very recently that this idea of a human biome has come into play as well. That was not even recognized maybe 20, 30 years ago in clinical medicine. Didn't have any meaning. But now it's part of all of this, because those 9/10 of the living cells in our body, which don't share our DNA, absolutely contribute to this. So why are we talking about this? Because in order to be able to deliver care anywhere, we need to be able to measure, and in some kind of way which is handleable and manipulable by basic tools and AI, we need to be able to measure that. And that's what our patient status engine platform does. So things that are starting to come into play are personalized, machine learning-based predictive algorithms or early warning scoring. And this is probably one of the best ones and one of the first. And this was work that we did several years ago now at the Children's Hospital in Birmingham with the development of the Rapid Index, based on a training set of nearly 100,000 hours of data, nearly 1,400 children who were monitored as part of this program, of which nearly 1,000 contributed to the training set. And this turns out to be a better predictor of deterioration across a wide range of children than the current pediatric early warning scores. So this work is halfway done. The next part of this is a prospective trial where we can take this and say, look, let's really get this technology, this kind of thinking into standard care. Right? Down here there's some information about some other, again, these are kind of focused on children, these programs, where in New York at the moment we have a big study underway with one of the hospital groups there, monitoring babies, but monitoring every newborn if they want to be monitored, even those who aren't necessarily going to go to the neonatal intensive care unit. And we need large numbers, so we need up to 10,000 babies. The clinical question that was asked there was, why was it that SUPC, sudden unexpected postpartum collapse, was increasing in that hospital? It's quite rare for something really bad to happen. Maybe 1 in 5 or 10,000 babies will die, but unexpectedly at about 12 hours old. So we're looking for early indications of that at a time in human physiology which is unknown territory. So we're picking up humans at 2 hours old and monitoring them until they leave the hospital at about 24 hours. And there is no literature. Nobody knows what's normal. It's new ground. And so we're looking for things that the prize here is going to be not only picking up those babies that would die, but also keeping babies out of the neonatal intensive care unit, which in the United States is about $20,000 a day that the insurers pay for that. So there is some real incentive to get that right. But we need big numbers. And this hospital believes that this monitoring of the physiology of the babies will become a new standard of care, because it will be so comforting and be so important in doing something else, spotting those babies which are starting to go febrile, or they're starting to become possibly septic, and not having to dose nearly everybody, every newborn, with antibiotics. So this way of being able to start to find those people who really need care. And here's something else that these kinds of systems are bringing out. And this is new directions in diagnostics. And this is a digital medicine at its best. And again, this work was done some time ago, but down at the Royal Free Hospital here in London, combination of the Royal Free and a hospital in Bonn, and that done with patients with advanced liver disease. And by monitoring, using one of our patches for about 20 minutes on a patient, information on the physiological status of that patient was gained, which was equivalent to the MELD score, which is a lab test, blood test, which is done on patients who come in, sit, have bloods taken, wait for their results at the end of the day, and they're told they can go home or they get admitted to the hospital. So here was a test that was able to say, look, here is the same information, completely different physiological pathway, but the same information. But something else popped out of that, and that is this score. The hepatologists had always known that if they had 100 patients at a particular level of that condition, which acute on chronic liver failure, pretty sick people, but they had 100 patients, about 50 of them would die within 3 months. They just never knew which 50. In this study, all patients who scored below a certain number didn't make it beyond 90 days. So some really significant stuff coming out of this idea of quantitative physiology, a sort of re-emergence of that. Really interesting stuff. And so what else are we doing? Where are we doing out-of-hospital work? Well, I can't really say very much about it because we don't like to do that. We've got a lot of work going on. We've got some great work going on in Scandinavia, in Copenhagen in particular. We're doing work with UK hospitals on their out-of-hospital programs. But we like to wait for our users, our customers, to be able to report in their own journals what they do before we blow it on them. So there's some good stuff happening in Switzerland in this area as well. But one of the most interesting things about this platform I've shown to you today is that it's affordable. We absolutely believe that to date, most medical devices have been part of an elaborate scam. Let's have drugs, but most medical devices. And that scam has been able to be perpetrated because the medical device manufacturers have said, it's so hard to do this. Everything has to be regulated. We can't change anything. Costs a lot of money. Bullshit, right? Here we have lots of things going on. Technologies have changed. Many of these devices are based on Tencent's semiconductor sensor technologies. Where is the other 10,000 in that coming from? So our ideas have always been, how do we make this affordable? How do we make it universal? And we are getting there. And I'm very proud to say that, I hate to see myself on screen, but this happened just a couple of months ago. So this is Mr. Karthik, who is the CEO of Manipal Hospitals. Manipal is the second biggest hospital operator in India, and they have decided that with our colleagues in India, they can use this technology because it's affordable and it gives them a digital advantage that really is something that we are not seeing from European or certainly from NHS customers. the management teams in those hospitals, they're driving them as private businesses, sure, but they see that digital enablement is going to be the key to greater efficiencies and hence greater profits for them. But only because we can make these systems affordable. So that's what we're doing. We would like to see this kind of technology spread around the world, and we can do it at a price point there which makes it affordable in India. And so really that's what I want to say. This platform is around, you can get it, it's available, it's being used in the hospital, out of the hospital, anywhere in between. This is a real virtual ward. It's able to deliver information on which care can be provided outside the hospital, but it has to be a new kind of workflow, a new pathway. Those workflows and pathways take a little longer to develop sometimes than the technology, but it's coming. And this is who we are, the clue's in our name, you see. So that's all, thanks.
Thank you so much. And thanks for helping us with the graveyard shift, of course, but hopefully you've got the right people in the room, despite the time of day. So thank you so much.
Well, I'm glad that anybody's in the room, so thank you.
No, not at all. You've got, I think, very important people that will discuss things with you.